we'll go ahead and get started with everything. I don't know what's up with my computer tonight. All right, let's try it. All right, so I know there's only about 5 of you guys in the class. So tonight, anybody have any questions from the last few chapters or quizzes or anything like that? All right, so tonight is going to be trauma, basically bleeding, shock, soft tissue injuries. Probably one of the more important chapters, just for, I mean, they're all important, but there is, this is what we see most often. This is what we can do more about, trauma as a first responder or an EMR than we can just about anything else. Okay, so that's why a lot of the things, a lot of skills, things like that are driven towards trauma. It's just something that we see more often, and that we're, like I said, we have more capabilities to deal with. Again, we're always going back to our patient assessment. Like I told you before, that's pretty paramount for us to be very good at, and that there's no difference here, with trauma. So it's really important that we do a good patient assessment and that we are really checking the body. This is where some of that stuff comes in, where we have to really, pay attention to, what the patient looks like, feels like, and it could, a lot of times with trauma, it can digress, it can go down pretty quickly. So especially for an adult, they can kind of go south on us pretty quick once the underlying effects of that trauma come into play. So again, one of the big things we're going to talk about tonight is shock and and its effect on the body and different types of shock. But internal bleeding, stuff that we can't really see, but we can see the results of it, and that results in some different types of shock. Again, shock is a state of collapse of the cardiovascular system and results in inadequate delivery of blood to the organs. So the textbook definition is inadequate tissue perfusion. Now, again, that could be inadequate tissue perfusion because the brain is telling the heart not to. It's because the heart is broken somehow. It's because it had too many bee stings, okay, or snake bites, or any number of different things, that could cause it to have shock. Not enough blood in the system, things like that. So there's a bunch of different reasons that cause it, but ultimately the end result is the fact that the body is not getting the delivery of blood that it needs to the vital organs and the rest of the body. So just kind of going through some of the steps here, and we're going to we'll talk about each one, and we'll kind of have some treatment options for each one. I'll try to expand on some of it. There is a lot of great stuff that I want to be able to tell you, but I also don't want to confuse you. So we'll probably talk about some things when we do our skills boot camp, and that way you guys are getting the information and for your tests and things like that. You're not getting confused, but I'm going to give you some good tips and different looks at different things for the real world. So again, doing our patient assessment, it really is more of a hands-on process. We can't be afraid to touch patients that are bloody and broken and torn up and everything else. We need to put our hands on them. We need to cut their clothes off. We need to be able to look at, or expose their body and be able to see what we're dealing with. Very often we have injuries that either are caused by outside sources or from, broken bones or ribs or something like that, that can cause very small, black and blue discoloration in certain area, or, there's a little bit of trauma or some type of punctures or anything like that that are very small that we can very easily miss if we don't do that. So it's important that we do a good head to toe exam. But first, we need to make sure that that scene is safe, right? We always talk about that. If you've been looking over your patient assessment checklist, which you should be doing, first thing, PPE, making sure the scene is safe, right? Number 2. So just making sure that we have, our PPE on and that our scene is safe for us to be able to operate in. Again, it doesn't have to be an active shooter or some crazy person, that we're dealing with. It could also just be down power lines. It could be, a slippery, wet hill that we're having to try to climb down to get to the vehicle that's overturned, or, again, an unstable vehicle that the patient's in, or whatever. So any number of things can cause that scene to be unsafe. So it says you may need to halt a primary assessment if the patient is losing too much blood. So it's one of those things we refer to as, we call it find it and fix it. Okay. So as we're doing this assessment, we're looking at the body of the patient. We walk up and you can see that they're obviously losing a lot of blood continuously. There's no reason to start, checking for airway breathing and all this other stuff. And, let me check pulses real quick. No, we don't need to worry about all that. If we see a life-threatening, injury or anything like that, we're going to immediately find it and fix it. Okay, so we're gonna control that bleeding or what have you. So as we go down, we may have to kind of jump back to the beginning or where we left off and start working our way back down. But nonetheless, if we see something that's life-threatening, we want to make sure that we find it and fix it as soon as possible. So during the secondary assessment, be alert for signs and symptoms of shock from internal or external blood loss. And we're going to get into what some of those look like here in a little bit. So, depending on your patient, whether it's 5 minutes or 15 minutes, we're going to watch the patient for the following signs and symptoms: pale skin, increased pulse rate, decreased blood pressure. Those are pretty indicative signs of hypovolemia or too much blood loss, things like that. Like I said, the heart is trying to race to try to get the blood out there and try to meet up with the demand of the loss. And the blood pressure is decreasing because the blood, there's not enough blood in the system. So the pressure is just not there. There's not enough fluid in the pipes to keep it going. So standard precautions, it's almost an absolute. You've got to wear your gloves. These days, of course, dealing with COVID and all this other stuff, we're used to wearing masks now. Everybody's got a mask. You'll probably see that just a lot more, even once COVID kind of goes away. You'll see probably more healthcare professionals in general, whether it's a dentist or an EMT or a doctor or whatever, using a mask. So they'll probably just up the standard of care to include, face coverings for when you're dealing with people like that. But nonetheless, again, one of the big ones that we do is absolutely wearing gloves. We're dealing with all sorts of different types of body fluids. Even patients have heart attacks and who are, have other types of signs and symptoms. Other types of medical issues, especially in trauma. You'd be dealing with, blood and body fluids and things like that. So we always want to make sure that we have our gloves on and we're trying to stay safe with that. All right. So we mentioned in the cardiac chapter, whenever we get to some of these other chapters, we're going to kind of expound on that. And so that's what we're doing. so a little bit more, you see a little bit more of the anatomy of the heart here and the actual pulmonary system or circulatory system, and its integration, as you can see down there on the bottom, is essentially where the lungs would be. So that intersection there at the bottom is essentially talking about the lungs, and its exchange of gases into the at the pulmonary level. But you see the arrows, how they kind of come in there, and it's ultimately, excuse me, ultimately there are, the heart again has to pump that blood out, get oxygenated, and then come back and get pumped back out. So it's coming in twice. Okay, so if you follow the blue, okay, the inferior vena cava, superior vena cava, blood is coming into the heart in the right atrium, right ventricle, and then out the pulmonary arteries, bringing it out to the lungs, transferring that CO2 laden blood. All right, trading that out for oxygenated blood. All right, gets oxygenated and comes back in the pulmonary veins, back into the left atrium, left ventricle. All right, and then back out, as you can see at the top, through the aorta. All right, and then once it does that, it's going to go out systemically, as you can see down there at the bottom, down there to get moved around through the distal part of the body, and then also up through the aorta, and then into to other arteries, and then of course up into the brain. It's really important to understand this process, so that you understand what's happening when these things take place. So we're going to talk about some of the issues that we have. So if, as you can see, the long tubes that are in this picture are the pipes. Okay, so we're going to talk about pipes and pumps and things like that in a minute. If you try to keep it simple like that, it's really not difficult to understand when we have things break. Okay, we don't have to use a bunch of big words and really terms and all these different types of processes and things like that. It really is it's a pump, and it has pipes and it has fluid, and the fluid is the blood. And so those arteries and veins and things like that, especially at the bigger level, whenever they are occluded or the brain tells them to constrict or open, we have issues. If there's an electrical problem with the heart won't pump as well as it should, then we have a pump problem. Okay, so the pump is broken some way, whether it's electrical or mechanical or something like that. It doesn't give us the opportunity to get the blood out in the manner that it should. So it's like I said, whenever we're dealing with some of these things and we say, oh, the heart's racing or the blood pressure's low or whatever, that's why those things are happening, is because one of these, or going back to the blood, there just may not be enough of it. Okay, and so if there's not enough of it, then the pump is going to have a hard time getting it through there. A lot of times when there's not enough of it, the vessels or the arteries and veins tend to constrict because the body tells it to, so that hopefully it can build up blood pressure. Okay, so if we have a smaller pipe, the pressure is going to be a little bit greater than when it was big. So they can expand and contract just a little bit, but that gives it some pressure, and the body knows it has that capability to constrict down and try to build blood pressure. Well, again, sometimes it's enough to do that on a smaller scale, but when you have a considerable amount of blood loss, it can only constrict down so much, and now your blood pressure is going to be low and your heart rate is going to be higher because the heart is trying to get that blood, it's just trying to speed up to try to get that blood, as much blood as it can, out. Okay, in and out. So again, and if we have issues like we'll talk about with the blood backing up into the lungs, we can have congestive heart failure, where there's essentially the blood is just pooling up in there and backing up and it's not able to get out, but it's just sitting there. And so it backs up into the, some of these vessels, and we have issues with there bleeding fluid around the heart and things of that nature. So going right into it, the pump, like we just mentioned, the heart functions as a human circulatory system's pump. It consists of 4 separate chambers. I mentioned that the left and right atrium and the left and right ventricles. All right, so here's a better look at it. Again, superior, inferior vena cava, bring that blood in. Essentially from your veins, right? So that's just like if we give a patient medicine, then it's going to come in through it's going to reach the heart by the superior and inferior vena cava. It's going to get there, and then it's going to get processed to the lungs. So again, comes in that right atrium, down the right ventricle, and then out the left pulmonary vein, or excuse me, pulmonary artery, and then out to the lungs. And you can see it on both sides, right and left pulmonary artery. So depending on which lung it's going to. And again, once it comes back from there, it's going to get pumped out to the rest of the body systemically. So we mentioned this when we talked about respiratory. Okay, that blood carries the arteries carry the blood away from the heart and to the lungs, and once it gets there, it meets up and gets oxygenated. Once it does that and it's oxygenated, it's going to go out to, as you can see, the artery. It'll break it down into its next branches, arterioles, even smaller into capillaries, and then whatever that organ is around that will get oxygenated, and then from there it'll take its waste products and all this other stuff, and it will bring it through to it'll essentially transfer it over to the vein at the capillary level, and from there it kind of becomes a capillary, a venous capillary, venules, and then the vein itself, and then that blood is going back out. Okay, so it oxygenates, transfers over, takes any waste products, and it brings it out and brings it back out up into the heart to be oxygenated again. Okay, and to distribute that waste products wherever it needs to go, depending on what it is. So that's kind of how that artery turns into a vein. All right, and it's it's a pretty neat process. It's happens at a microscopic level, and it really is. If you think about the very tip of your pinky finger or your pinky toe, that's where that stuff is happening at the capillary level, and then up around your skin at the capillary level. And so these bigger arteries obviously are bigger tubes. Arterioles branch down into smaller ones, and the capillaries are very small. So the fluid, or the blood itself, is the liquid part of the blood, is plasma, and the red blood cells carry oxygen and carbon dioxide. The white blood cells consume bacteria and viruses to combat infections in the body, and platelets from the form clots that help stop bleeding. So we're going to talk about that. I'm not going to get too much into what we call the clotting cascade, but we'll make reference to that. And why it's important for temperature and things. When we talked about skin, we talked about keeping people warm and controlling their body functions, right? So that definitely has a big part in our shock management. So a pulse is the pressure wave generated by the pump action of the heart. Okay, so every time the heart pumps out blood, we get a pulse. Okay, so in a conscious patient, you can easily find the radial pulse at the base of the thumb. So if you follow the side of your thumb as it's looking at you, right? So it's in its anatomical position. The thumb is out to the side. but we're looking at down the outside of the thumb, and where it meets the wrist at, right in there, about 2 finger widths, and that's where you'll find your pulse, right in between that and the tendon right there. So if a patient appears to be in shock or is unconscious, attempt to locate the carotid pulse. Depending on the patient, if they're unconscious, just go straight to the carotid pulse. Just make sure that you have a pulse, and we can work to the wrist and see what you have there. If you have a carotid pulse, if you can feel a radial pulse, you can generally assume, again, this is just a general assumption, that you have a systolic blood pressure of at least 80. Okay, of at least 80. That's not necessarily the number that it will be, but that just lets you know, hey, they have a pulse, and they have a pulse in the wrist and the radial pulse, and so more than likely their blood pressure is going to be at least above 80. So, and that's kind of the cutoff there. I mean, that's just the general good rule of thumb to assume that, but we're still going to check that blood pressure and see what the actual numbers are. But in a pinch, if you just want to see kind of where your patient's sitting, it's good to go ahead and do that, and that kind of gives you a little bit of information about what's going on. All right, shock is defined as failure of the circulatory system, and it is again, it manifests itself in a lot of different ways, and it could be a failure, like I told you before, a failure of the pump, the heart itself, the pipes, the veins or arteries, or the blood is having some type of fluid loss. Okay. So in pump failure or cardiogenic shock, it occurs if the heart cannot pump enough blood to supply the needs of the body. So again, it could be electrical, could be a blockage in the heart, that's not allowing it to get blood to it, and so again, poor perfusion, right? So it's not able to get the heart is not able to get perfused its own self. Okay, so we mentioned that in that heart chapter, cardiac chapter, where we talked about the vessels that supply the muscle of the heart, the outside of the heart that does the work. It has to have good oxygenated blood as well. Well, when that doesn't happen because of a blockage, usually in one or multiple vessels, then the heart muscle can't pump as well. So then we go into cardiogenic shock. So inadequate pumping of the heart, again, can cause blood to back up in the vessels of the lungs, resulting in congestive heart failure. This is what we were talking about earlier, right? So if it's not able to pump it out enough, whatever's sitting in there is just going to start backing up into the vessels of the lungs, and then you have congestive heart failure. And there's a lot more about congestive heart failure out there, and you welcome to look into it more, but we're not going to get super deep into it more than we already have. So we talked about pipe failure. So if we have a pipe failure, is caused by the expansion of the capillaries to as much as 3 or 4 times their normal size. Okay, so if for some reason the brain tells them, hey, you need to expand out, try to make some room here, the blood pools in the capillary. It doesn't have enough. It's just not touching all the walls of that pipe, and so if you try to flow garden hose type water pressure down an 8-inch water main, you barely, it's only going to touch the bottom of the pipe. It's never even going to think about touching the top of the pipe, and therefore it's not going to have any greater pressure. Okay. So the rest of the body is deprived of this blood, and because it pulls up in those capillaries, and the blood pressure falls and shock results. All right. So we really need something that will help constrict their vessels to create some pressure, or fill that void with blood, or with a bolus of blood or fluid to be able to get that pressure up. Another pipe failure, again, shock induced by fainting or psychogenic shock. So it's essentially, again, fainting, and ultimately there's just not enough blood. The blood is being occluded somewhere, and generally that's, you've heard of people locking their legs out. Some like military people, and they're standing at attention too long, they lock their legs out, and it kind of occludes the blood flow north and south there, and they pass out. So generally, all you have to do is lay them in a horizontal position. Usually raising our legs up a little bit in that position will fix that problem. So, anaphylactic shock. We mentioned this not too long ago when we talked about poisonings and things like that, right? Environmental emergencies, and it's essentially whenever you have something that somebody's allergic to, or it's a great enough histamine or something like that is caused the body to react abnormally. And it can be, again, numerous foreign substances. People are allergic to all sorts of different types of things, grass, and like, of course, bee stings, right? Also, in any number of things. But generally, the patient appears flushed. Breathing might become difficult, and blood pressure drops rapidly. It says death will result in prompt action if prompt action is not taken. Again, it's not always the case. You could just have localized swelling and things of that nature. But if you're in actual anaphylactic shock, then we're kind of, it's a little bit different than just straight anaphylaxis. Okay. Anaphylaxis would be where you have your swelling, maybe your throat closing a little bit, things like that. But if we are in full blown anaphylactic shock, our patient is not responding to that foreign substance very well or at all, and the body is not able to do much for it. So the body is going to try to protect itself, and sometimes by doing that, you end up with the body in shock. And like I said, it's going to try to rapidly try to get that blood out. It's going to try to open those vessels up and get that blood to where it needs to go, or constrict them down to make it tighter. Depends on what it is. And and if we have the the right tools and things like that, we can try to help prevent that. But ultimately, it's going to be it's usually going to be a medication of some type that's going to have to be administered to help with that. So spinal shock, it occurs in patients who have sustained a spinal cord injury. The injury allows the capillaries to expand, and blood pools below the level of the injury. The brain, heart, lungs, and other vital organs are deprived of blood, resulting in shock. So again, remember that spinal cord is, it's the lifeline. It carries all. That's why it has all those bony processes all the way around it. Not only does that give us structure, gives our body form and structure, but it is the great protector of all those incredibly important nerves and vessels, and vessels and things like that. So it's really important that we take it very cautiously when we're dealing with spinal injuries, and making sure that we are really doing a good physical exam, that we understand what's going on if we have spinal injuries, and then we also have some of the classic signs of shock. Then we put those two and two together, and you get spinal shock. So it's one of those things where a lot of those are very dependent on that spinal column for function. So if we have that have that damage to the spinal cord, then everything below that could be out of commission. Okay, and so when that happens, we lose some of those cognitive abilities, some of the ability for function, obviously, so we know about paralysis and things like that, but also some of the actual body functions below that may not be functioning as well. So it's important that we get them packaged and correctly and have them transported immediately and make sure that we are taking every precaution we can. Fluid loss. Fluid loss is caused by excessive bleeding or hemorrhage and is the most common cause of shock. Okay, so again, for the things that we see most often and the things that we are seeing in society now, with active shooters and explosions and of course all the numerous vehicle accidents and things like that we see all the time, this is one that we really are concerned about. It's really something that we can do a good bit about, especially on the external side. So this would be hypovolemic shock. Hypovolemic shock is low blood loss. I mean, a high blood loss, low blood levels, right, in the body. So the blood escapes from a wound and the system's total fluid level drops. Now, again, this could be internal or external, but the heart begins to pump faster to maintain pressure in the pipes. The pump eventually stops pumping, resulting in cardiac arrest. So there again, it is imperative that you control any external hemorrhaging as fast as you can. Okay. The external bleeding, again, is easy to detect usually. I mean, you can kind of tell where it's at. We'll talk about blood volume here in just a minute, but it's important that we realize that, and that could be anything from blood-soaked clothing. Maybe if you had a bystander there that had a towel or a shirt or something like that was trying to control the bleeding. You see those laying around, the pooling of blood in that area. Those are all just visual indicators. Obviously, the blood flowing out, of course, but those are visual indicators that, hey, this person has lost a considerable amount of blood, and so that's a main thing that we really need to be looking for. So the bleeding with internal bleeding, you can't really see it, but we can have bruising, swelling. Another big one is rigidity in the affected area. So especially for abdominal injuries, we can have a rigid abdomen. Okay, so we try to press on those different quadrants of the stomach. We run into, or the abdomen, we run into a hard, rigid stomach. That's a good indication that there's some type of pressure buildup, and blood loss. Severe pain in the immediate area, it could be in any number of things, but also when you have a rigid stomach, severe pain in the same area, bruising, all right, that gives you kind of a localized indicator that, there's probably going to be some internal bleeding, okay? So we see that a lot with the seatbelt, all right, across the stomach. If it's not worn correctly, not worn over the hips, it's worn on the belly. We can have those types of things. Somebody who's not wearing a seatbelt, you may have impacts to the steering wheel or other parts of the vehicle. Maybe if they were thrown out of a window and maybe they were laying over the windowsill, something like that. Of course, any of these types of injuries could happen for a lot of different other traumatic events, not just vehicle accidents, but that's one that we deal with very often. So, again, you could have the same thing in a football accident. Somebody gets hit really hard in the stomach and there's no padding at all for the stomach, in football. So if you catch a helmet or a foot or an elbow or something like that in the stomach, you may have some of the same things. So when the bleeding is external or internal, whether the bleeding is internal or external, if it remains unchecked, the result will be shock, pump failure, and death. Okay. So again, life-threatening bleeding is usually going to be more so on the arterial side. We see that because it has more pressure, but we can still see it on the venous side. However, the arterial side is typically going to exit the body faster. So this is something very important to remember. All right. An average adult has about 12 pints or 5.7, say 6 liters of blood. Okay. That's the average adult now. Okay. So, of course, children, it's going to be less. But the average adult has about 12 pints or 5.7 liters of blood circulating in the system. So it says here the loss of 2 or more pints can lead to shock. So generally, we're going to start to see a change in their level of consciousness. So when they're starting to get weak and woozy and things like that, at around the 1.5 to 2 mark. Okay, anything above 2.5, all right, that's almost half of our blood volume. All right, 2.5 liters of blood. All right, so think about that in 1 liter or 2 liter Coke bottles. Okay, if you want to do it, later tonight or tomorrow or something like that, get you a 1 liter, 2 liter drink. Finish it off, fill it up with water and red food coloring, or something like that, and pour that 1 or 2 liters out on the ground. All right, and see what it looks like. Pour 1 liter out, see what that looks like. Pour another liter out, and see what that looks like right next to it. All right, that'll give you a visual representation of how much blood. When you walk up and you see all that blood, that much blood, you can kind of say, hey, that's pretty close to that puddle that I made, and that's, I know that we're getting around the 2 liter mark, and we really got to act fast. Okay. After about 3 or so, you can pretty well hang it up. All right, 3 going into 4, you can hang it up. Your patient's not going to do very well at all. Okay, you have to infuse a strong amount of blood real fast, and generally in the field it's not possible. Okay, so it's one of those deals, like I said, where whether it's especially on the external side where we can really do something, we of course we won't know about the amount of the internal bleeding, but the abdominal and pelvic cavity can absorb and can accept a very large amount of blood. Okay, so if they do have serious internal bleeding, it can definitely hold a whole lot of a considerable amount of blood in these areas. So as you can see there, 3 or so pints in the pelvis, 3 or so pints in the abdomen, 3 or so in the chest, and so as you can see there, that's a considerable amount of blood that can be held in those areas without ever setting a drop on the ground. All right. So again, when you see these signs and symptoms, you need to start moving pretty quickly and let's get something done about it. They need to be transported quickly. If it's external bleeding, we need to try to stop that bleeding as fast as we can, and we're going to talk about a few ways to do that. So signs and symptoms of shock. Again, shock deprives the body of sufficient blood to normal function or to function normally, and as shock progresses, the body alters its functions in an attempt to maintain sufficient blood supply. The main things again with shock are confusion, agitation, restlessness. There's sometimes, like especially a little bit later, there's cool and clammy skin and maybe pale skin, and again some of that blood is being pulled away to try to support the main body functions and organs, and so it's gonna try to pull that blood away from the exterior and the distal parts of the body and pull itself into the core, and that's the body compensating for shock. and that's we refer to those. We're not going to get too deep into each one of those, but compensated and decompensated shock. Compensated shock would be, again, the body's kind of natural responses to shock, and trying to work through it. The others, the decompensated shock, is when the body can't keep up with its with those issues. Okay, and so it's going to it's going to, like I said, have a hard time keeping up with it, and we're going to have to try to step in there and help out. So again, some of those signs and symptoms: rapid breathing, rapid weak pulse, increased capillary refill time, nausea and vomiting, weakness or fainting, and thirst. Again, these signs and symptoms could be a few different things, but if we couple it with the fact that they have lost blood, or that they have the rigid abdomen with bruising, and they're confused, agitated, clammy, cold, that sort of stuff, we're starting to get into the realm of, hey, I'm pretty sure this patient's in shock, right? So position the patient correctly. It's as long as they don't have a head injury, or extreme discomfort or difficulty breathing, lay the patient flat on his or her back in a horizontal position. Elevate the legs. Doesn't have to be super high, but you want to get them above the heart. And make sure that they, we're trying to get some of that blood back to where it really needs to go. Again, the arms and the lower extremities are going to have are going to have to go without for a little while during this time, but it's okay, because we really need to keep the brain, the heart, the lungs, and things like that oxygenated. All right, so again, we're going to maintain the ABCs as usual. Those are the big three, and again, if we're doing the big three, we're probably doing the right thing. And again, if you try to keep it simple like that, we're working through the ABCs. Is the airway open? Yes. Are they breathing adequately? Yes. On the circulatory side, are they bleeding out? Yes or no? Do we control the bleeding? Yes. Okay. And do we help the circulation, problem? Probably so. Right. So, of course, we're going to check pulses and blood pressure and things like that, and check to see if the circulatory system is doing what it needs to do. But again, we're looking for those issues, and we're going to try to fix them as best we can. So again, we want to try to treat the cause of shock. So again, we've mentioned multiple different types of shock and reasons for shock. So if that's the case, we want to try to fix that problem. We're going to probably help fix the shock. But again, if the patient is in decompensated shock, it's going to take a little bit more to try to reverse that. Again, do not allow the patient to eat or drink. A lot of times these patients are going to end up going to surgery of some type, or at least having some type of procedures done, and we don't want them to have anything on their stomach. So eating or drinking, again, may cause vomiting, and patients in shock may need surgery, again, like I said, and should not have anything in their stomach. So assist with other treatments if you're trained, which we are. We're going to provide O2. It's like I said, it's usually a good idea, especially in shock patients or trauma patients, to deliver some O2. Helps oxygenate that blood a little bit better, and get that blood oxygenated when it may not be able to get as much as it should. So obviously, when the EMTs or paramedics get there, they're probably going to start an IV or two, depending on their blood loss. So if they did lose a considerable amount of blood, they may not. They may start an IV, but they may not push a whole ton of fluid until they can get some whole blood products to replace, because that's really the best replacement for that blood is blood. For a long time, the big thought was if they lost a lot of blood, we're going to give them a lot of fluid, in general IV fluid, which would be in this case, in hypovolemic case, would be lactated ringers, and we found that that's a better option than nothing, but what it does is washes out the like I said, the clotting cascade, which is the body's natural defenses that are going to that site, the red blood cells, things like that, and white blood cells that are going to that area to help to fix that problem, fight the infection, and build more clots and build natural clots in there. And so really what we want to do is support that clot building by keeping the patient warm, okay? Having a cold, the patient being cold really slows down the clotting cascade and the clot building capability of the body. So we want to keep our patient nice and warm. We want our fluids to be warm or body temperature, and we want to ensure that we're not washing those away or doing anything to fight against the body's natural ability. So treatment for shock caused by pump failure. Again, the pump failure is a serious condition. A lot of times we're not going to be able to do a ton for that. Biggest thing is going to be prompt transport by ambulance to an appropriate medical facility. That's going to give them the best chance for survival. If there's ACLS trained personnel, paramedic, things like that on flight nurse, flight paramedic on scene, then they may be able to do a few other medications or electrical therapy for that patient. But as far as our scope of practice, our biggest thing is going to be apply oxygen, keep them comfortable, keep checking our vitals, and again, if it's something that we can shock them with an AED or something like that, we can do that. Of course, if it goes into CPR, cardiac arrest, then we'll be doing CPR. So treatment for shock caused by pipe failure, like I said before, if it's anaphylactic or something like that, or if the just for whatever reason those pipes are not doing what they're supposed to do, again, same thing. We're going to transport as soon as possible. And some patients, again, if it is anaphylactic and we have an EpiPen or an epinephrine auto injector, we're going to assist them with that. Remember, we're not necessarily going to administer it for them. Again, if they have an EpiPen, support the patient's thigh, place it right there on the tip of the auto injector after you take the safety off, the safety cap, and put it against the outer thigh and the meaty part of the thigh, and you don't have to slam it. You're just going to put pressure against it and push the auto injector firmly against the thigh, and it will automatically inject in there. And hold it in place for several seconds, let it deliver the dose, and take it out, and make sure you notate what, where, and how it was administered by the patient with you assisting. So treatment for shock caused by fluid loss. This is for internal blood loss. Again, looking for any type of ruptured vessels, tumors, any number of different things that might cause internal bleeding. It's some of those that sometimes you may see it come up like, vomiting blood. Sometimes the blood, if it's been there for a long time, could be, look like coffee grounds. That's usually some pretty serious ones. That's, like I said, it's probably going to be a chronic issue there. But you may have, bright red blood. That's new blood that comes up. So that's something that we might be concerned about. Excuse me. Abdominal tenderness, rigidity, bruising, just distension. We talked about that, where the belly is really distended out and kind of rounded. Rectal bleeding, same thing. You may have different colors of blood coming from the rectum or the vagina, just depending on how old the blood is and what it's coming from, whether it's an artery or a vein. Venous, again, like we mentioned before, venous bleeding is a little bit darker, and arterial blood is is a more bright red blood. So you want to be in an EMR, and this is where it gets to be where, like I said, we can really start to do some good. And this is also too where it takes having a strong stomach sometimes, having having the ability to kind of turn off your internal will to vomit yourself or be disgusted by things and smells and sights and sounds. And when we're talking about trauma, these 3 pictures are nothing. I mean, realistically, that's a bad cut on the knee, whatever. But when we're talking about complete, de-skinning of a person's body part, or decapitations, and having their entire abdominal cavity ripped open, things like that. I don't tell you these things to scare you or disgust you, but I want you to be prepared for these types of things. If you've never seen that in real life, I would probably look through some pictures and see if those are things that you can handle, and make a personal decision to either press forward or to work through those things. And it's because it's going to be the first time that you see those things does not need to be on a scene. You need to have seen those things and tell yourself that it's okay. You're here. You're there to do something to make that better. It is bad. I mean, just like this guy down here in the hockey suit here, bleeding out, probably cut by a skate or something, and that's a considerable amount of bleeding right there. So blood in general, I mean, of course, like I said, we talked about this earlier with universal precautions. Blood can have several, depending on what the issues of the patient are. They could have all sorts of infectious diseases and everything else in them, right? But as long as you are protecting yourself, you're wearing your gloves and your mask, and and your patient, there's a lot of blood everywhere. Your patient has a lot of blood all over them. They're holding on to you. Yes, your uniform is going to get bloody. Whether you were the fire department, law enforcement, EMS, whatever, you're stopping on your way to Disney World to help somebody, you're going to get bloody. Okay. So that's one of those things where I would prepare for those types of things. Have an extra, long sleeve shirt or something like that available, long pants. I wouldn't treat somebody who's, a traumatic event in flip flops and that sort of thing, right? So, having closed toed shoes and that sort of stuff, if, to help protect yourself, but nonetheless, don't be afraid to get blood on you, because that's, a lot of times we're going to have to really, put ourselves out there, and to help people, we're going to have to get some of that stuff on us. It's almost inevitable that that's going to happen. Of course, we're going to decontaminate ourselves as soon as we get the opportunity to, change out our gloves for especially for another patient, or to to go forward and do more treatment. Our hands may be covered in blood, and it's going to be super slippery. We just need a new pair of gloves so that we can do a better job of maybe digging through the bag, digging through the ambulance, for more equipment or something like that. We don't want to get everything else in our bag all messed up. So another good thing about preparing equipment, things like that, if there's a lot of bleeding, you're going to need a lot of bandaging material, then it's probably a good idea to go ahead and take all that stuff out of your bag, lay it out, and that way you're going to have to dig through the bag with bloody gloves. All right. So again, if this stuff makes you queasy, makes you feel weird or whatever, that's just a personal thing that you're going to have to overcome or not. There's plenty of people who just are not willing to do that. And it's understandable that you may take this class and never touch blood again in your life. But again, it's one of those things that I've seen considerable amounts of serious injuries, extremely morbid, horrible injuries, and so it's one of those things that, again, don't be afraid to get up and close and personal, because the sooner we can stop that bleeding, the sooner that we can start to actually treat the patient and give them the care that they need so that hopefully they'll survive. Okay. So like we said before, we have, there's three types of vessels: capillaries, veins, and arteries. The capillaries are those little small, small vessels there towards the top of the skin, and then down to the small appendages and things. And it's probably the most common type of external blood loss, the paper cut, the, skinned elbow or whatever. Those are things that usually ooze out. That blood just kind of, just like when you cut yourself shaving or something like that. And you have a little nick here and there, it just kind of slowly comes out, and you have to pat it a few times to get it to stop, right? Direct pressure to the site of that is what's going to stop it, okay? Again, it may take it a little bit. You have to hold it on there for a little while, but applying direct pressure to that site will help control that. Venous bleeding, like I said, is the second most common type, and this bleeding has a steady flow. So again, if you were to cut a vein of some type, then generally it can still flow out considerably, but it won't necessarily have the pressure that an arterial bleed will. It'll have, like I said, it has more of a flow out type effect. Again, same thing, applying direct pressure, to that area or right above that area, it will be your best bet for trying to control that bleeding. The big one that we're really worried about is arterial bleeding. And so every time that blood spurts or surges out is kind of in sync with that heartbeat. Okay. So every beat that happens, that you're getting is going to be blood loss. Okay. So, if you get, if your heart rate goes up and we're at 100, 110 on a heart rate, that's 110 pumps of blood that are coming out within a minute. Makes sense? So it's one of those, again, we have got to get on this fast. All right. Direct pressure, again, is going to be that key factor. Now, when I say direct pressure, it's not necessarily going to be external direct pressure. It can be, and we're going to do that, potentially if we can't control the direct pressure just from the outside, right over the top of it or whatever, for a smaller arterial, bleed, great. That's awesome. Chances are, if you have a serious arterial bleed and an external bleed, you are going to have to do something a little bit more invasive. So, bear with me. These slides are not catching up. Are you guys seeing the picture of the foot? There we go. All right. So when we do this, again, we may have to put direct pressure with a tourniquet or wound packing or something of that nature. These slides don't talk a lot about wound packing. We'll talk a little bit about tourniquets when we get into the skills lab. We will definitely do wound packing. You'll see what I'm talking about here. But ultimately, if the wound is large enough and you have an arterial bleed, we are going to have to get down to the source of bleeding. Okay, where the actual vessel is broken or where the artery is broken. That's where we're going to have to put our direct pressure. Okay, that's the epitome of wound packing. We're going to have to get down inside the wound with our finger and put pressure directly on the broken artery. Okay, you want to talk about blood? That's going to be a lot of blood. All right, a whole lot of blood and a whole lot of pain for your patient. No other way around it. Okay, a lot of times we do this We do this in areas where we can't apply a tourniquet to. So generally the groin, the armpits, and the neck. All right. So if you think about the body, the torso as a box, okay, so your chest, abdomen, groin, neck, armpits, if you think of that area as a box, all right, we pack the box. All right, so we pack the box. We tourniquet the limbs, okay? So the limbs anywhere south of the shoulder, south of the pelvis there, or the groin is going to get a tourniquet. So if we have bleeding anywhere south of there, that's where we're going to tourniquet with. So the other one would be pressure points. So putting a direct pressure on so this is elevation. And again, this may help with light blood loss, if it, again, venous or something like that, capillary bleeding, that it'll help to alleviate that. If in a extremity, if you raise it up above about the level of the heart, that will give you help to alleviate some of the pressure on it. Again, just one of those old school ways of dealing with blood loss. But again, for a serious arterial bleed, arterial bleed, it's not going to be that effective. So, so again, for those tourniquets, we're going to, it's going to be indicated by, again, life-threatening bleeding. If you see life-threatening bleeding from an extremity, if you have a tourniquet, you don't wait. Put the tourniquet on, okay? A long time ago, that wasn't the case. We tried all these other things first. People died. And then we're like, oh, well, I guess we can try to use a tourniquet as a last-ditch effort. But, they thought they had all these crazy side effects and all this other stuff. And science has just proven that that's not the case. Iraq and Afghanistan proved that that's not the case. All right. So military medicine, helped to define a lot of the things that we deal with now in trauma. And so it's important to understand that this is a tourniquet is a first line device. Like I said, if it's something that can be controlled by direct pressure or elevation, that's great. But we're not gonna wait too long in order to put that tourniquet on there. All right. So if it is life-threatening bleeding, go ahead and put the tourniquet on first. If it's marginal bleeding and it just won't stop, then we may have to put a tourniquet on. So with direct pressure, we also have pressure points. For the extremities, it would be right there around the front of the shoulder. So around the front of the shoulder for the arms, and then the right there in the groin, right in the bend of the bend of the hip there in the front, and that area right there in that femoral artery where it descends. That's where we're going to put a strong amount of direct pressure. It's a very large vessel right there. It's going to take a considerable amount of pressure. Usually the best thing is a knee. All right. For an adult, it's going to be your knee in that spot. And obviously we're going to be looking at the bleeding, and we're going to be kind of moving our knee around until we find a spot that controls that bleeding. Again, this is extremely painful for the patient. However, this is life over limb. They'll probably try to fight you a little bit. They're going to be screaming in pain. And unfortunately, it's something that we may have to do in the event that we don't have a tourniquet, that we're going to have to do in order to control that bleeding. Okay. So your best efforts, your partner's best efforts, things like that, bystander, family member, something to try to keep them calm, try to help them breathe through the pain, things like that. And try to keep them calm, but nonetheless, it's going to be very painful to have another grown adult put their knee in this top middle of your leg there, essentially right around the hip area. And so like I said, that is a pressure point there, and also, like I said, the front of the shoulder. If we put probably both hands down on that, where it transverses over in the front there, and then goes down the arm. So right there in the front, you're just below the clavicle in the front of the shoulder, is where that vessel kind of runs there, and it's going to be, again, very painful as well, but it won't take as much pressure as a femoral artery. So those are pressure points for stopping bleeding and external bleeding in the extremities. So again, right there, kind of where they're looking at here, the brachial artery also is one. So if you have marginal bleeding and you just want to slow it down or something like that, you could also use the brachial artery. And the brachial artery there in the upper arm. And this would be one for children and babies, things like that. If you have an external, extremity hemorrhage in a baby or small child, same place we check for a pulse on a baby, in the brachial artery there, this would be where we would apply that pressure. But for adults, if you have, again, we want to, if we can't, especially if it's maybe say a amputation or partial amputation high up in that arm, like around where that person's fingers are, if that injury is way high up there, then the only place we're going to have to go is the front of that shoulder. All right, so we mentioned it earlier. Again, I can't stress it enough. They're just going to become, one of your most used item is going to be, nitrile or latex gloves. I would just get warm and fuzzy with, what fits you the best. For me, I don't have a huge hand, so I want to have a nice snug glove that I can really feel, I can write with, I can check pulses with, I can squeeze the ambu bag, I can open medicines, I can do all sorts of different things at a very tactile level, but I'm also protected. So that's the way I like all my gloves in general. But so find what size works for you. There's small, medium, large, and extra large. That's generally what you're going to get. Most of the time, people can kind of fall in there. And like I said, it's good to have them a little bit more snug than loose. That way you don't tear them as easy, things of that nature. Of course, it's always a good idea if you're going to be in this field. For those of you who have longer fingernails, male and female, you may want to think about a better nail cutting regimen to keep from, puncturing your gloves. It happens pretty easily when you have fingernails. It doesn't take much friction, and it'll cut those gloves. But again, you're going to use them very often, and so even if you do get blood on your gloves, it's a good idea just to wash your hands after you get done, and just make sure there's no small holes or anything like that in your gloves that could have got in there. And we just want to double check and make sure that you've washed them. If not, like I said, a lot of times in the back of the ambulance, I'll have some type of disinfectant. Of course, now everybody and their mama carries hand sanitizer and, rubbing alcohol from the distillery that makes hand sanitizer and all this other stuff that we have out here now. So we're all pretty well versed in hand sanitization. So any number of things out there on the market are usually pretty good. So just get something that'll take care of just about everything, and keep some of that with you. Some of these little small bottles that you see, go in your car or go in a lady's purse, or something for the office or whatever. Those same little small bottles, great plastic. Throw them in your medical kit, and you already have some right there. All right, we'll take a break right here, and we'll catch up with wounds, and we'll start going into wound care here in just a minute. So take 10 minutes. All right, everybody, we'll go ahead and get started. Start again, and touching on wounds. Again, a lot of different types of wounds out there. I mean, they as far as how they can look, but basically we classify them as open or closed. And the wounds can be, as far as closed wounds, like we mentioned before, internal bleeding, internal injuries, any number of things that can be going on underneath that skin, underneath that tissue. So generally the only closed wound is the bruise, and it's something that we can see from the outside. Injury of the soft tissue beneath the skin, small blood vessels are broken, and the area becomes discolored and swells. That's essentially what a bruise would be. Bruising and swelling may be a sign of an underlying fracture. Again, if you can do that type of damage to the tissue, then you may have the ability for a fracture to be there. Open wounds are generally what we're going to see, and that's a break in the skin. Abrasion would be more like a road rash or a little scrape or something like that. We as a kid we fell off our bike, right, and we have a little bit of road rash or something like that. Occurs when the skin is rubbed across a rough surface, and it could be any number of things. So sometimes it may be a little bit more gnarly than that, but it still is the same depth of skin. It's just taking off that top layer, and you have more capillary bleeding than anything. So you can see that down there towards the bottom, actually, where it's kind of oozing out just a little bit there at the bottom because kind of gravity's pulling that blood down. So a puncture would be any type of penetration into the skin. So a sharp object penetrates the skin. A knife, doesn't necessarily have to be sharp. It could just be a jagged object. So any type of puncture may cause deep injury that is not immediately recognized. The puncture wounds do not bleed freely. Usually, it may take it a minute for it to start bleeding. An impaled object sticks out of the skin. So if you have, like I said, a stick or a knife, any number of things that could get stuck in the skin, but it's, if it's essentially, it's impaled if it stays in there. So if it stays in there and it didn't get pulled out or didn't come out on its own, then it is impaled. And if it broke the skin and went in there, then it's punctured, and it came out, then it's punctured. Okay. So a gunshot wound is a special type of puncture wound. In and of itself, yes, it is a puncture. However, it generally, the wound channel, the length of the wound itself is longer than most things would be. Okay, so that makes it different. So as you can see here, we've seen this a lot of times. If you ever worked around construction or anything like that, you've probably seen somebody get shot with a nail gun, and it's fairly common. even at the experience level, it happens. So, but like I said, a stick or any small, on a small scale, and then like I said, you could get a puncture wound impaled by a pipe, right? So those of you may have seen the pictures, videos of a tree trimmer. I think it was in Florida, and he fell and got impaled by a part of a tree. He cut the tree off. He's conscious and alert the whole time, and they transported him to the hospital with a tree through his abdomen, then out his through one of his buttocks. So it went down, it went through his pelvis and missed a bunch of stuff. Went through his stomach, his abdomen, and missed a bunch of stuff, displaced a bunch of stuff, and was sticking out of his abdomen. Is near his rectum and his buttock. So many things like that overseas. We've seen rockets. We've seen people with there's some pictures out there of a rocket that didn't detonate. That is same way. It's kind of like through and through their abdomen, sticking out of their back. and that was a very tense time dealing with that. I didn't have to deal with it, but just in general, they have essentially a bomb technician and a surgeon working hand in hand to ensure that that gets defused, no pun intended. So laceration is more of an open wound, more of the open wounds that you see a lot of times. You may call it a cut, but it ultimately, it's something that is down. And generally, these kind of work their way down the layers of skin and tissue. So this one just is going to go a little bit farther down into the tissue. Minor lacerations, so you have minor and larger lacerations. Those minor ones, again, typically are direct pressure or Band-Aids, that sort of thing. And, wash it off, put a Band-Aid on it, and you're good to go. Large lacerations, however, can cause extensive bleeding, can bleed for a while, and could potentially be life-threatening depending on where they are. So again, this would be, this is obviously the front, the patella kneecap area. So a very large laceration there. However, they don't always bleed excessively, especially in an area like this, depending on what's there, which may be a vein. You're probably, popliteal vein, which you could get, popliteal arteries in the back, but you may have a dorsal vein there that, if you ever flex your knee and feel around, you'll see a little vessel there. And so that vein, might bleed a little bit, but typically it's usually may stop on its own. So it just depends on where it's at, how much it's going to bleed. If there's a lot of fatty tissue or muscle around the area, generally you're probably not going to bleed very much. And it looks bad, it looks gnarly, but you put some decent direct pressure on there for a little while, put you some bandages on it, and you'll probably be okay. But you take the same type of cut there, and you put it you put it somewhere else, especially like the scalp or anything like that. You're going to have bleeding, a considerable amount of bleeding there. Avulsions and amputations. Avulsions are the forceful tearing away of tissue. And so again, we're kind of taking that same cut, but then we're pulling it back. We're it's taking a chunk out, per se. And, so it could be a bite, some bites are avulsions. A lot of times where, something gets maybe punctured and then pulled at the same time, that may cause an avulsion. And again, if an entire body part is torn away, that's an amputation. The amputated parts should be located, placed in a clean plastic bag, kept cool, and taken to the hospital for possible reattachment. It's not up to you to decide how or why that's going to happen. You just need to collect the body part and follow those steps and send it with the ambulance. If they need it, they need it. If they don't, they don't. It's up to them at the hospital. It's not up to us. Okay. So do your best to preserve that limb or digit or whatever it might be, and take care of it. So that's kind of an avulsion there. You can see it has some grass and different things in it. It's it's more of like the side bottom of the knee there, the popliteal area, and it is as you can see, kind of torn away. There's not a cover on it, if you will. There's not a skin flap or anything like that. The skin has been ripped away from it. So again, these are what you see a lot of times in traumatic incidences. Wrecks, things like that. You get these bad cuts and avulsions just because of the way that the speed and the ferocity of what's going on. So, like I said, it looks bad. Even looking at it right now, obviously it's in the hospital, but everything. You have all this stuff that's exposed. You see up here at the top of the avulsion, you have these little whitish colored bubbles, and that's just fat tissue. All right, that's just that lower level of the skin, the fatty tissue made up of that, and as you go in, you see some muscle, and you may even, you don't really see tendon right there, but you look down a little bit more of the bottom part behind that red part at the bottom of the avulsion, and you have a tendon right back behind there. So again, it's not bleeding. So if I were to walk up and see it in that condition without, with that amount of, with no blood, it's just not going to concern me. I know that I realize that it hurts, and it's probably going to burn and be painful and everything else. It's absolutely understandable, and we're going to care for it and clean it up and everything else. But if they're short of breath, if there are bleeding from somewhere else profusely or something of that nature, this wound right here does not bother me. Okay, this does not get me excited or make me want to, wrap it up immediately or whatever. Okay, to the average person, they will lose their mind over that injury right there. Okay, so especially because they'll want to drag you to it. Oh, look how bad this is. Look how bad this is. And that's one of the things we have to pay attention, or we have to really focus is not to get drawn away by injuries like this. Okay. Again, yes, it will get taken care of. It's in there, right? As we look down our trauma assessment, especially in our reassessment, secondary assessment, as we come down to it, yes, we're going to inspect, palpate, assess motor sensory function, things like that. So once we get back down there, we'll reassess it, we'll dress it up, and get it cleaned up and things like that, and get it ready for transport. But if it's especially fractures that don't involve bleeding or anything like that, same thing. I'll give you a perfect example. Yesterday, I went to a lady who had fell about 6 feet down some stairs, and elderly lady, and she kind of a bigger lady. She fell down, hit her head. Complained it had a little hematoma on the front of her head, had a big knot, and she had a finger on her left hand that was angulated. It was obviously broken and dislocated, and was just sticking out the complete opposite direction of where it needed to go. The family, same thing. She's complaining of her head hurting, all this other stuff. Her hips are hurting and everything else. She has multiple traumatic injuries. And they're constantly telling me about her finger. And, so at one point I just had to let them know, hey guys, listen, there's absolutely nothing I can do for the finger. There's nothing the paramedic can do for the finger. It's going to be okay. It's not bleeding. She's not complaining. That's not her worst complaint. Her worst complaint is her head. And that needs to be the focus right now. And so, kind of had to reassure them that I'm aware of it, that I'm knowledgeable in the fact that it's broken, but it's not something that I have to be concerned with at the moment. Okay. And rightly so. The paramedic is never probably going to touch that finger. Okay. We never, he's really more focused about her head injury, and her vital signs and things like that, and her cognitive abilities, whether she can move her arms and legs and all that sort of stuff, versus, worried about one broken finger. All right. So again, don't get drawn into some of these bad, crazy looking injuries if they are not life threatening, or if they're not going to make something else worse. Okay. So like I said, just be cognizant of that. So again, very minor bruises need no treatment, like, kind of what I was mentioning there. These minor things, there's not a whole lot we can do about them. Again, putting a dressing over it or something like that might just kind of keep their eyes off of it, some of these minor injuries, but keep it from bumping on something, or if it's something where we're going to have to go through something dirty, drain pipe or some, the woods or whatever it is, and we don't want it to get messed up anymore. Sure, we'll wrap it up, clean it up, and make sure it doesn't get anything else on it or in it, and call it good. But closed wounds, things like that, applying ice, gentle compression, even elevating that injury, these sprains and strains of the ankles and wrists and that sort of stuff, elbows, again, if we immobilize it, splint that area, and then we go from there. It's again, splint all major contusions. So especially if it is around a joint or an area in the extremities, if it's considerable, amount of bruising, then yes, we want to we want to try to splint those areas, because more than likely there's probably going to be a fracture. You know, if it had enough force to cause that type of bruise, there's probably good potential for a fracture. As I told you before, stop bleeding as quickly as possible using the cleanest dressing available, direct pressure on the pressure points, or a tourniquet. So dressing and bandaging. This is, again, another skill that we'll get into during the boot camp, and it's kind of an art to some degree. You can fumble around with it and look silly and waste a lot of time, waste a lot of materials and things like that doing this. Okay, again, this is one of those things that we can do. We don't need ALS intervention to do it, and we need to be good at it. Okay, and so I'll give you some tips and tricks when we get in there, and we'll talk more about it, and we'll show you a few pictures here. But it is a skill that you have to practice a little bit to get good at, and make sure that you are knowledgeable about the different types of materials and things like that that are available to you when it comes to this type of stuff. But big thing we want to do is control bleeding, prevent further contamination, immobilize the injured area, and prevent movement of impaled objects. So a dressing is an object placed directly on the wound. Okay, so we talked about bandaging, and bandaging is what holds it in place. So a bandage holds a dressing in place. So just remember that. All right, so we put, and you see some measurements down here: 4x4, 5x9, 10x30. The 4x4 is by far the most common piece of dressing out there ever made. Okay, you know, the 4x4, it comes in a little, paper wrapper or plastic wrapper, and it's just a 4x4 piece of gauze, 4x4 square piece of gauze, usually bifolded, and we use it for all sorts of stuff. It is essentially the dish towel of the EMS world. Okay, it cleans up everything, it dries hands, it wipes down stuff. I mean, it does everything. Okay, so it's if you get in the 5x9 and 10x30, typically you'll have those. They're they may be called an ab pad or something like that, and they are for heavier bleeding areas that we need to cover. They're just to cover a larger wound type area, but in general, a lot of times, for the majority of things that we see of 4x4 or a few 4x4s are easy to grab and easy to store, and we can do a lot with those as far as the dressing part goes. So again, once it's in place, apply firm manual pressure to try to stop the bleeding. And again, it kind of depends on what you're going for there. If it's light bleeding and we're just trying to control it, then that's what we want to do. However, if it keeps bleeding through those, then we're going to have to take more drastic measures and provide that direct pressure to the pressure points, or again, a tourniquet or wound packing, something like that. So like I said, a dressing is something that keeps those bandages in place. Okay. So we can apply compression with those. A lot of times the biggest one that you'll see, and you don't see it on this picture, but there's a lot of different names for it. And rolled gauze is probably the most generic name. Cling is another name. They have some that's like real flat looking gauze, and they have some that is like wavy. That's usually cling. And it's just a more wider, bulkier, more fluffy type dressing. So with that, man, I mean, there have been restraints made out of that. You can, you can tie a patient's hands together, if they're unconscious. You can, of course, we can go around the head. We can go around the body. We can, make multiple wraps around an arm or a leg and really provide some tension and compression. And that's a lot of times when we make a compression bandage, we take the full roll of it, put that on as a bandage onto the wound, and then we'll take the rolled gauze and wrap it around that and around the typically the arm, and or the arm or leg, and then we will again by compressing that bulky dressing, we've created a compression bandage. Okay, compression bandage is a bulky dressing coupled with a bandage on top in a tight in a snug manner, and creates that pressure down on top of the wound. Okay. So again, like I said, it holds dressings in places. We've rolled gauze, triangular bandages. Another one's been around for like World War One. You know, so it's very old tech, and there's a lot of different versions of it out there. But most of the time, you see something like a linen type cloth. It's in a triangle type format, and once you unfold it all the way, it's still in a triangle or a square, and you fold it over into a triangle, and we can make a sling and swath, or a sling for an arm to sit in. We can take and wrap that around. Wrap two legs together and use it for ad hoc splinting. Same thing with arms. So any number of things you can use a triangular bandage for. It's just something good to have in case you need it. They make a lot of different versions of it now. But this is at its most basic form, is just a linen cloth. A lot of times you see here it has some safety pins with it if you want to try to connect it or tie it up into a knot. But a lot of other stuff out there, a whole lot of Gucci, high end, $25, $30, $40 per pack of one thing of gauze, type stuff out there. And we see that a lot in tactical medicine and military medicine. We have a lot of cool, innovative stuff out there. And, it does help, especially, create clots and contribute to the clotting cascade. And so, we have, we'll show you some of those in the skills lab. We're not going to worry with it tonight, but there are again a lot of cool things out there that we can utilize, and we can put in place to help stop bleeding, especially when we're wound packing and things like that. So at the basic level, we want to ensure that the dressing completely covers the wound, extends beyond all sides of the wound. It's not just, a little bitty, 4x4 on a, 6x6 wound, right? Or a 6-inch wound. We want to be able to cover all that up. So we want it snug, but we don't want it so tight that circulation is cut off, to that area. So anytime we bandage or splint or anything like that, we want to make sure that we are checking, making sure we have distal pulses, capillary refill on the fingers, things like that. And especially on the body, that we have good breathing and circulation and things of that nature. Depending on where it's at, what it's holding in place, if it's just more of like a cover up than an actual compression, we may take the end of it and just tuck it in there underneath, or we may tape it. We may take some medical tape, cloth tape, something like that, or silk tape, and go around the circumference of the injury and secure the end of it in place. So it just kind of depends on what you're doing. If it needs to be really snug in place, we may tuck it, tie it, tie it and tape it and all sorts of stuff to keep it in place. But again, like we talked about before, we may be dealing with these wounds and trying to get down into the source of the bleeding and trying to debris some of the wound a little bit, get some of the stuff out of there and washing them out, cleaning them out, and all sort of sort of stuff. So again, having good quality medical gloves and wearing them is vital. For those of you not familiar with nitrile gloves, nitrile is a non-latex glove. So there are people who have a latex allergy where their skin breaks out, you have swelling, all sorts of different stuff if they come into contact with latex. And so for medical providers or especially patients who may have a latex allergy, it behooves you to wear nitrile gloves in that case. So I carry gloves all the time. On my duty belt in law enforcement, I have gloves on me all the time. I, restock them every time I use them. And then, of course, in all my medical kits, I have them in different places. If you take them out of these, they usually come in this cardboard box. It looks like a shoe box. you might have 100 something gloves in there. If it's easier for you, get you a little sandwich bag. You put, maybe 6 pair in there or something like that. Take all the air out, roll it up. You could put it in a pocket, put it in a little kit, something like that, something along those lines. And you have plenty of gloves, and all you have to do is just refill them every so often. And that way you have several pairs to give to people to, again, if yours break or get soiled, you can change them out. So. Face and scalp wounds. The face and the scalp, for those of you who have ever, like I said, cut yourself shaving your face or your hair, have no doubt experienced a little nick or cut that just would not stop bleeding. And that's because the face and the scalp is very vascular in nature, so it has to support it has a lot of stuff that it needs to have blood flow for, and there's not a whole lot of fatty tissue or thick skin and things like that in this area. So a lot of those little small vessels and stuff are very close to the skin. All right, so it doesn't take much at all. A little nick to the top of the head, and it'll look like there was an axe murderer. Okay, so again, another one of those things where you get the call of there's a person down and they're bleeding from the head. All right, I understand. We get it. And no doubt that it could be a very serious head wound when you get there. But a lot of times it's because they have a little nick on the head, they got some glass in their head, and they cut their head open, they cut their scalp or their face, and it's bleeding a decent amount, but nothing that's going to be life-threatening. Another story from today, elderly female fell front steps. She's normally a little confused and shaky on her feet. And she went outside and just fell face first onto the concrete. When I got there, there's probably about I don't know, maybe about a 6 to 8 inch wide puddle of blood, a small light puddle of blood, not pooling, but where the concrete was stained with blood, and some drops kind of in certain areas. And then I looked at her, and she has what looks like a boxer's cut. If you ever look at boxing or MMA, when somebody gets a little cut above their eyebrow, and that's exactly where it was at. Probably about an inch or so long, and just a couple millimeters wide, or just like a millimeter wide. And they had no more bleeding. Bleeding was controlled on its own, and that's it. So she had lost the blood she was going to lose. The body started clotting for her, and luckily she wasn't like on blood thinners or anything. And she, the bleeding was already controlled. There was nothing on top of it. Didn't have to do anything. Didn't have to hold anything. Looked at it, opened it up a little bit, see how deep it was, and I just left it open so the paramedic could see it. Nothing else that I could do for it. Okay, so other than, like I said, putting something over the top of it just so it doesn't get dirty. I'm not going to wrap her head up like a mummy just for that. I mean, literally, they're going to end up probably putting a couple stitches in it, and or staples, or even with her age could be possibly a butterfly band-aid or bandage, and essentially that goes on there, has little wings on it, and essentially it's a closure, so at an adhesive closure, and they close the wound, put that on top of it, and it pulls the skin against each other, and keeps the wound closed until it can heal on its own. So again, looked bad, bunch of blood on the ground, elderly lady. You can get really focused in on this cut on her head, but ultimately, it's very minor. Okay, so however, nonetheless, we want to investigate those, especially when you have a lot of hair on the head. Females, things like that with a lot of hair, males with a lot of hair. We want to kind of work our hands through that bloody hair, and let's try to find the source of the bleeding, and let's try to put something directly on that source of bleeding, as well as checking for any type of skull fractures, loose skull segments, chipped skull, things like that, avulsions of the scalp or anything like that that's laid open, flapped open, things of that nature. And that's going to give us an indication maybe of where there could be some type of skull fracture in that area. So nonetheless, we want to be very careful with the head, if we're going to put them on a board or if we're going to transport them, probably a good idea to maybe put like a folded towel or something along those lines under the head, just kind of give it a little cushion, and probably going to help your pain level a little bit for your patient. You don't want to put their potentially cracked skull on a hard board and strap it down. So. Also, if you have head injuries, we all will suspect the neck and spine to be injured as well. So again, spinal precautions may need to be taken, again, depending on the mechanism of injury, the MOI, or, and things surrounding that. So we can, use our best judgment whether or not we need to, do a full spinal mobilization. Nosebleeds, again, sounds like a small thing. Many of us probably had a nosebleed for one reason or the other. Could result from hitting your face on something, or getting punched in the nose, or your little brother kick you in the face, or whatever it might be. Or it could be from dry air. High blood pressure is another one that we see. So if you do have somebody who has an extremely high blood pressure, there's always a potential for a nosebleed. And a lot of times it's just spontaneous. We really don't know the cause of it. But nonetheless, have them, again, if they're losing a ton of blood through their nose, that could be a sign of some type of head injury. So it may not just be the nose itself bleeding. It may be coming from somewhere else and exiting out of the nose. So again, one of those things where we need to be, pay close attention to our patient. And so if we need to treat them for shock, we'll do that. But ultimately, we're going to have them sit down, tilt their head slightly forward. And if that kind of keeps going, we can pinch the nostrils together for 5 minutes. And, leaning the head back usually just kind of makes it run down the back of the throat. And I don't know about you, but I really don't want to drink that much blood. Plus, it can upset your stomach if you do that. So, again, lean slightly forward, pinch the nostrils, hold them together there for a little while. Try not necessarily right at the tip, maybe a little bit farther up the bridge of the nose, kind of on the more, structural part of the nose there. That's where those vessels are going to be. And that's where we'd like for you to hold that pressure. And again, if it persists for a long time, severe bleeding, obviously we want to try to transport. So. Eye injuries, again, it's a very sensitive area. For those of you who may wear glasses or contacts, I'm sure, you've had, or been around, sand or sparks or anything like that. You may have had some type of general eye injury. However, the eyes, again, are very sensitive. So it doesn't take, it takes an eyelash to irritate your eye. So you can imagine if you actually cut, the eye in some way. Or have some type of actual laceration or impalement of the eye, things like that. An object stick into the eye itself. It's going to be very painful, and you're going to, the eye is just going to go crazy. The other eye is probably going to close, so it's going to be hard to open one eye and keep the other eye closed. So, anytime we have those types of issues, probably the best way to do that, if it's just lacerated in some type of way, like I said, it's very minor, then we can cover one eye and try to get somebody to drive them. May just need to go. They don't necessarily need to go to the hospital per se. They could just need to go to the eye doctor. But if it is something where it's an actual external injury, they're probably going to turn them away and have them go to the hospital and have an actual eye specialist or surgeon or something like that can ophthalmologist that can come in and actually perform some type of corrective procedure. And so there'll be a specialist that comes in and deals with that. But again, just small, light foreign body, again, anything from the eyelash to some sand or anything like that, generally flushing it out with normal saline solution, eye wash solution, is the best way to deal with that. And we usually have the patient lay on their affected side, and then that way that that fluid will come across the eye and then exit out the other side. Impalements of the eye, like I said, is another story. Generally, when we have something in there, like I said, a lot of times it's going to move back and forth as the eye moves. We really don't want that to happen, so a lot of times what we do is we'll cover both eyes. May sound a little silly, but it's just kind of a physiological thing where if we cover both eyes, generally you're not going to look back and forth. Okay, you're probably going to be your eyes are going to be a little bit more relaxed and not feel like the other one has to keep up with the one that's open. So the best bet, even if you have one good eye and one with a stick in it, let's cover up both of them, and we'll get you to the hospital and we'll get it worked out. But again, the eyes are also very resilient. I mean, as sensitive they are, there have been people that have been stabbed in the eye and have, again, pencils in the eye and any number of other things, and have had success with having their vision restored. So it just kind of depends on where in the eye it gets damaged. So neck wounds, like I said before, this is one of those areas where we can't tourniquet it. Okay, so direct pressure, yes, and but again, it needs to be direct pressure. If it's just a light, like it's a light cut or something like that, and there's not a major artery involved, then a carotid artery involved or something along those lines, then sure, we can place our gloved hand or a 4x4 or something like that against it, and we'll try to control the bleeding. However, if you have, there have been potential like bites, gunshot wounds that have grazed, knife wounds that have lightly cut the neck, and maybe a little bit more towards the back there, away from the carotid artery, and you get more of a thicker part of the neck, and it has a cut there. You may not have a whole lot of bleeding. All right, you may have a big chunk taken out of the neck, but it's not involving the carotid artery. It's not involving the spine. It's kind of right there in the middle, and we get lucky. Okay, if that's the case, we put a bulky bandage on there, and we'll try to secure it as best we can without affecting the airway and breathing. But ultimately, that's kind of how we'll handle that. However, if they're kind of where his fingers are on the left-hand side of the picture, if that's a pretty significant wound, and they have a, like I said, a gunshot wound, stab wound, any other type of, open wound, and they have the carotid artery affected and bleeding, you have a very, very short window. I mean, just a minute or two for these femoral artery, carotid artery, things like that, and you're going to be dealing with a patient that's getting close to that 2.5 to 3 liter mark, okay, of blood loss. So it will come out very fast. All right, and the brain is obviously not getting that blood, so your patient is probably going to be unconscious pretty fast, and definitely going to have a decreased LOC. And so when that happens, we need to get in there and get that pressure. We need to put that direct pressure directly on that bleeding artery. Okay. So again, we'll do that with feeding small bits of rolled gauze in there, or gauze that's in a longer section. So usually like 4 yards, and we'll take that and fill that void up at the same time we're applying that direct pressure. So those areas of the neck and the groin, back of the buttocks, things like that, things that we can't tourniquet. Those are that's kind of how we're gonna have to do it, is get directly down in there and put that pressure on the actual bleeding location. Okay, again, uncomfortable, painful, things of that nature, but something that's going to have to be done, or else that patient will die. Okay, they will rapidly progress through shock and then cardiac arrest and then death. Okay. There's a great video, if you if you YouTube it, it's a military medic on a helicopter that is putting stuffing this guy's neck, the soldier's neck, with gauze, and it's more towards the front, but I don't know that the artery is actually severed, but there's a significant amount of bleeding, and there's a large hole there. Again, everything is different, right? Every patient is different. Every wound is different. So you really have to look and see what's affected. It may look bad. It may look really bad. I mean, somebody could have a sword through the front of their throat, okay, or a kitchen knife or whatever, and just not hit that artery. And so it looks horrible. The wound looks horrible. All the stuff is exposed and everything else. But nonetheless, they can sometimes they might be able to breathe and everything, but the wound just looks horrible. But it's not life threatening. Okay. Yes, it looks bad. It's going to need surgery and all sorts of stuff. But, so again, one of those things where you really have to kind of investigate, start adding things up. Can they breathe? Yes. Are they bleeding excessively? Yes or no? No? Okay. We're good. All right. We don't want to move them a whole lot because we don't know what's actually been affected. So we want to try to keep them still, put a bandage, like I said, fill that void with bandage, keep some direct pressure on it, and maybe even put a C-collar around their neck to kind of keep their neck from moving around, that sort of thing. That might be a good idea, or just hold their neck in place. And again, it's going to be a pretty dicey situation until you can get them transported. Chest and back wounds, of course, we want to place the patient with a chest injury in a comfortable position and, a position that helps them breathe. If a lung is punctured, air can escape and the lung will collapse. You may have heard this called a sucking chest wound, and essentially any puncture anywhere above the belly button. Okay, so good rule of thumb: anywhere above the belly button, if they have a puncture or something like that, and if you have bleeding or anything or air escaping, anything of that nature, we're going to put an occlusive dressing on it. Okay, an occlusive dressing is essentially something that's going to cover that wound but allows air to move in and out. Okay, it allows air to move out and not in. And so that occlusive dressing, like I said, usually is something plastic, sticky, or taped on there. That's usually the best type of method for that. Again, there's a lot of great adjuncts for, we call them chest seals, out there on the market, and they're kind of the go-to. They're really not that expensive. They usually come in a pack of 2 for entry and exit wounds. So if you do happen to have a gunshot wound or stab wound or something like that, we're always assuming that there's a potential exit wound. And so anywhere, again, above the belly button, the navel, we want to assume that it is affected the lung, because again, when those lungs inflate, they can go way far down. That's why our ribs go down as far as they do. Okay, is to protect the lungs whenever they fully inflate. So if that patient was at full inflation whenever they were stabbed or shot, or had their wreck or whatever it might be, and their rib broke and punctured a lung, then or something came in there and punctured their chest, then we want to ensure that we are not allowing more air to come into the space between the lung or the chest wall and the outer part of the lung. Okay, this place is called the pleural space. The pleural space. So when that happens, the more air gets pulled in there through negative pressure, and it will start to form essentially a bubble of air on top of the lung and keep the lung from expanding. Okay, so the more air gets pulled in, the bigger the bubble gets, the less the lung is able to function properly and inflate properly. All right, so we want to quickly occlude that penetrating hole, or that hole that's been penetrated there, and we want to try to keep that outside air from coming in, and any air that is able to be forced out stays out and doesn't come back in. Okay, so again, any puncture of the chest or stomach, it's just a good idea to go ahead and put a chest seal or an occlusive dressing on that. Typically, a homemade occlusive dressing could be, some type of like sandwich bag or something like that, Ziploc bag type thing. You gotta get creative there. Plastic wrap, taped on 4 sides. You usually leave a corner of the bag untaped, or the plastic piece untaped, and that will allow the plastic to, when there is an inhale, for it to seal against the wound. When there's an exhale, there's a small hole there for the air to escape. Okay, so it doesn't need to be super thick, so that it can have a little bit of movement, so it can actually lay down on top of the wound and stop the air from coming in. Always a good idea in these cases to administer oxygen, because again, they're going to be taxed. Their breathing is going to be taxed, and we don't want that to happen. Again, seal the wound and monitor the ABCs. Like I said, if it's been a little while since it happened and you're just now getting to them, they may start to have some breathing difficulties. Usually painful breathing is going to be a big indicator, a big sign that you might see. And they may be giving you a symptom of difficulty breathing. And again, their heart rate's probably going to go up, things like that. If you do happen to have a seal that doesn't have a vent on it, if you have it on there and their breathing gets real labored, you may have to essentially burp it. So lift it off, let the air escape, and then put it back on really quickly. And that just, you may have to do that every so often. For those of you who have ever watched Three Kings, the movie Three Kings, they're out in the desert, young man gets shot, the colonel or whatever, special forces colonel, comes over there, sticks him in the chest with a needle, and then he starts turning this thing off and on, and tells Mark Wahlberg to turn the thing off and on every so often. And that's essentially what he's doing, is he's essentially decreasing or slowly letting that air out as it builds up. Again, great videos out there of internal video of the lung, a punctured lung, expanding and contracting and bleeding and losing air and things of that nature. I have some other videos I'll show you later, probably of the external part of that, a very large open wound to the chest, and you can see the actual in and out movement of air against an occlusive dressing and then without the occlusive dressing. So impaled objects, there are, it's like I said before, you could have a tree throughout your whole body, or a very large knife. If you just Google impaled objects, and you'll find thousands of pictures over the years of people that have been impaled by incredibly crazy things, day-to-day things, weird stuff. All sorts of different things out there. So, again, like I told you before, have an open mind, and we're not going to try to judge people, but there are, again, a lot of things that are going to test your understanding of humanity sometimes. But there are definitely a lot of things that go into that that you have to be concerned with. Biggest thing is stabilizing the object, and that's kind of where we come in, is going to be ensuring that their ABCs are good as best as we can get them, and stabilizing that impaled object. It's, again, sometimes very tricky. We may be part of, like I said, there have been people in New Orleans that are impaled by these wrought iron fences that are all around town there, and they have to cut them off, transport them with them. There's been people been impaled by alligator gar, fish and stuff like that. Animals, in numerous different ways, like their claw broke off. I mean, there's all sorts of. I mean, from, like I said, to trees, to to fences. You have people that crash a car, run through a fence, or run through the woods, and they have limbs and fence pieces of fencing, wood pieces, things like that are impaled in their chest and their neck and their head. I mean, there's a fantastic video. I mean, I think it's a picture of, it's side by side with an X-ray picture of a man sitting up on the bed on the exam table in the ER with a 10-inch kitchen knife stuck straight in the center of his head, halfway down in his head, so like 4 or 5 inches in his head, and he's sitting there awake and alert, very little bleeding, just waiting to be treated. And next to the picture is a picture of him, his X-ray, and you can clearly see the kitchen knife 3 or 4 inches stuck in his head. So again, you have to be very careful with some of these things, and just really try to stabilize it as best you can. A lot of the ways that we do that are these bulky dressings. So as you can see there in the center picture, that would be something we would refer to as cling. However, it could be something like pillows or rolled up blankets, sheets, that sort of thing. And then we'll have to kind of put it on both sides of it, kind of keep it in place from wiggling around. And then, as you can see there in the center picture, also they have some bandaging that's up underneath it, and that just kind of helps absorb some of the blood that might be coming from it. And after that, we'll just take our cling and roll gauze and whatever tape, whatever else we might need, and go around that object. Around our dressing, and around our bandaging and around our bulky dressings, and keep those snugly in place. So you have to kind of get creative. There is no one way to do it other than, again, using bulky dressings to kind of keep things in place. That's the kind of the general rule. But like I said, you may have to get creative depending on what it is. So closed abdominal wounds, result of a direct blow from a blunt object. So again, a baseball bat to the stomach, or like I said before, a football injury or soccer injury or something along those lines. Again, person gets ejected from a vehicle, the stomach hits the steering wheel, hits the person flying around in the car, their arm hits them in the stomach, any number of things. Okay. But nonetheless, we're looking for bruises, any other rigidity, any other marks on the stomach, abrasions. And whenever a patient experiences shock, there may be internal abdominal injuries. So if you have the symptoms of shock, but they just haven't developed yet, you really can't tell where it's coming from. Always start looking towards the abdomen, chest, things like that, and see if there's any of those signs and symptoms of internal bleeding. So if the patient is vomiting blood, it may be an indication of bleeding from the esophagus or stomach. Same thing. We're looking for any of those signs and symptoms of decap BTLS. We mentioned that before, right? Deformities, contusions, abrasions, tenderness, swelling, any of those types of things. We're looking for all that, and in those areas. Same thing. We're going to monitor the airway and the vital signs just to make sure that none of that is affecting their airway and breathing. And of course, especially, like I said, it's just not common for people to vomit blood, so we want to get them to the hospital and get them checked out as soon as possible. Open abdominal wounds, again, another one of those things that will really draw your attention. It's, again, not something that we see very often, and so that, therefore, whenever you see the intestines protruding from the stomach like that, it is very eye-catching, and you tend to kind of focus on that, and you want to cover them up and all this other stuff, and you want to do something with them. A lot of times we are not going to do much with them. Okay. If now, varying degrees here. Okay. We have a knife cut to the stomach or whatever, and you have you have, what looks to be, uncooked sausage, in a link, which is the intestine. Basically, one part of it is just pushing out, maybe a, 4-inch piece or something, or a 6-inch piece or whatever. That in and of itself, not a huge deal. We'll cover the area with a sterile dressing. We'll take one of those abdominal pads, a little bit bigger pad, put it over the top of it, and keep it real clean, and wrap it up and transport. When you have a serious open avulsion, essentially, of the abdomen, where all of the intestines are essentially exposed, laying out there, that's a different story. They are usually not very easy to manage like that. They're kind of all over the place. They don't really stay where you put them. So you really have to maybe use multiple different pads. Definitely some bulky dressings, and a lot of cling. And hopefully you can try to, get the patient's hips elevated and try to go around them. So if you have like a towel or something like that, if you can put a towel up underneath their buttocks or the lower back, and that way you can kind of pass that rolled gauze around them. That would be the best bet. Again, it looks like something that would be a mortal wound, something that would, just kill them instantly. They should be dead. But that's not necessarily the case. And so you may have their abdomen, almost wide open, and they're sitting there talking to you or screaming in pain or whatever. So, again, it's a very ominous injury to look at. And again, sometimes it's very difficult to deal with, but ultimately do your best at as sterilely as you possibly can, put those intestines back into the stomach cavity, just on top of the stomach cavity, and cover them up and keep them secured. For those ones that are just kind of popping out like that, we don't want to try to push them back in. Okay. So again, like I said, if it's large and open, there's no choice but to put them back on top. That's one thing. If they are just a small cut and they have a small, some protruding, we're not going to try to shove them back in there. Okay. So again, do your best to collect them, keep them secured, and as clean as you can. Okay. And sometimes it may be hard, but we'll try to keep them as clean as possible. There's just a couple pictures there, just of open abdominal wound type scenario. Genital wounds, again, another one that's, not easy to deal with, male or female. However, it is very vascular as well. The penis and the vagina and things like that are, again, have a lot of blood supply to them. That's essentially what drives them to function. So it's definitely something that we have to, of course, we're going to go in as modestly as possible with our patient treatment, and things of that nature can be embarrassing for our patient. So, we try to, maybe make have some people hold a sheet up around us or something like that, or, have the patient, put in the back of the ambulance before we do some of these things. But either way, if it's severe bleeding, we need to control that bleeding, and we need to find the source of it. So because of that, we're going to need to get them what we refer to as trauma naked. Okay. And that's with any of the stuff that we're talking about. If you have these significant bleeding and injuries and mechanism of injury, we need to get our patient trauma naked. They're going to do it at the hospital anyway. So it's best if we have a patient with serious injuries. Again, if somebody has a cut on their arm, we're not going to cut all their clothes off, right? So that's just common sense. So try to think about it, a little common sense with that part of it. But however, again, if we have multiple injuries, multiple areas, we're going to need to expose at least the majority of those areas, and typically shirts, pants, that sort of thing. Underwear we might be able to leave in place depending on what's involved. But again, in this case, if there are genital wounds, we may have to remove the underwear and, open the legs, look in there, move things around, and find the source of the bleeding. Okay. Same thing, unconscious patient, multiple injuries, that sort of stuff. We get them trauma naked. We need to roll them over, look at their anus and see if there's any, blood or body fluid coming out of there, in the genitals, anything like that. Take a quick look, make sure there's nothing going on there, and then we'll cover it up. Okay. So again, we'll do our best to try to, maintain their modesty, and not embarrass them as little as possible. And, but at the same time, we're going to still try to apply that direct pressure, with a dry, sterile dressing, and ensure we're trying to control that bleeding. So like I said, it does have a lot of blood flow to that area or those areas, and they will bleed quite a bit. Extremity wounds. Again, we kind of talked about this in each one of these sections quite a bit. Like I said, dry, sterile compression dressing and a bandage is secured in place. Elevate the injury to some degree if you can. It kind of helps decrease bleeding and swelling, and a lot of times it's on the minor side to do that. Again, if you have extremities that may have underlying fractures, not a bad idea to splint them. So if you have the bleeding controlled, and you want to kind of, and especially if they're unconscious and they can't, or they are conscious and they can't tolerate the pain, or they, it's one of those areas, an obvious fracture, obvious closed fracture, then it's best to go ahead and splint it. So again, like I said, if it's minor, we can put a little direct pressure on there right over the top of the wound, put a bandage on top of it, keep it in place, nice and snug without cutting off the circulation, and you're usually pretty good. However, if that keeps bleeding through, it won't stop, can't get it to stop, put on multiple dressings, won't stop, or it's absolutely, from the get-go, we've noticed life-threatening bleeding, that is not able to be controlled with direct pressure, then we're going to go into putting a tourniquet on, okay, right away. So we touched a little bit on gunshot wounds. Like I said, the gunshot wounds are a little bit different than a lot of things because they affect several different parts of the body at one time. There's always, like, it says here, the trunk and neck are major cause of spinal cord injuries, and that's one of those that we need to be worried about, which way the bullet went in, and we may need to try to see where that exit wound is, if there is one, and try to start to formulate an idea whether or not that the the spinal cord is involved in that. Of course, anytime we're dealing with this stuff, like I said, these bullets, from a 22 to a 300 blackout or a 30-06 or whatever you want, whatever you want to, look at. I mean, obviously, depends on the range and the type of round and where they're hit and all this other stuff. Same thing as the knife in the skull. Okay, we've seen people get shot with 50 caliber Barrett 50 caliber sniper rounds and live from it. Okay. I mean, it just depends on where you get hit and things like that. All right. We've seen people get shot with a 22 pistol, a tiny little round, take one round in the right spot and die immediately. Okay. So don't ever just look at it and go, oh, it's a little gunshot wound, not a big deal. All right. You need to really be looking at the totality of what's going on here, and start to treat the patient accordingly. All right. Don't focus on the hole. Don't focus on, the gun laying there or some of the blood or whatever. We really need to focus on the patient and what their vital signs are, where the wound track is, and, what that bleeding looks like. Okay. In the wound track. So the wound track essentially is that tunnel that the bullet creates as it goes through the body. Remember, whenever the bullet is traveling, it's spinning, it hits a solid mass, like the front of the stomach, let's say. Okay. Now, once it goes through there, it's typically going to slow down, but it's also going to continue in a more of a tumbling type motion. Okay, so it's going to spin a little bit the first part of it, depending on the speed of the bullet, caliber, things like that. But ultimately, it's going to start to tumble or expand and fragment. And so that wound path, that wound channel, is typically going to be made wider by the velocity of the round. Okay, so that air around it, things of that nature, and the blood pushing past it is going to cause that channel to expand. Some of those little fragments from the bullet and bone that it hits along the way, things of that nature, are going to be deposited in the wound tract. Once it continues to tumble to where it either stops or exits the body, we can have all those different fragments all throughout that wound tract. All right. So again, pieces of metal, copper, lead, bone, shirt, anything else that might have been on it. Say law enforcement officer, you may have fragments of, if it goes through a vest or takes part of the vest with it, so you may have pieces of Kevlar or metal or something like metal from the plate along with that, or any other piece that it penetrated. So if it penetrated wood or metal door or glass, you could have small fragments of that get carried into the wound tract. So again, things to be thinking about when you're dealing with that. Depending on the size of the wound, we may have to do some wound packing depending on where it's at. Like I said, if we're dealing with the torso, right? So the neck, armpits, groin area, lower abdomen, things like that, we may have to do a little bit of wound packing to try to help that, but we're ultimately not going to be able to pack the entire wound channel. Okay, we're just not. So again, every wound channel is different. You may have a graze, a slight in and out. We had a drive-by shooting not too long ago. We had a gentleman that was barely grazed. With all the gunfire, you would have thought he'd been hit multiple times, but he was only grazed one time on the hip. Had I don't know, maybe just a very small amount of bleeding, just enough to make a few little droplets on his pants, and that was it. All right, so a little direct pressure, a little bandage and tape, and he's good. All right, so and then some of them are large open exterior, exit wounds. So a lot of times the entry wound may be smaller, and again, some of these even like rifle rounds may enter the body very small, but after it tumbles through there and then comes out, it could be, depending on what it hits along the way, it could have a very large exit wound. All right, so anytime we have an entry wound, we're always looking throughout the entire body for an exit wound. Sometimes they're very obvious. Like I said, they could be very large, or they are very small as well. Okay, and so there are a lot of times where you have to almost take your fingers and claw around the skin to expose them. They'll almost self-close and be very almost like a little slit in the skin. But it's a full-on, gunshot wound channel. All right. So again, be a little bit of a detective and look around for these wounds. Again, they don't always start bleeding very fast. Okay. So some will start. It depends on what they hit. If there's an artery along that wound track, you can bet your bottom dollar you're going to start getting some serious red blood spurting out of that wound track or out of that hole, that entry wound. So again, be very cautious of that, and be cautious about putting your finger in those wounds if they are a larger open wound channel. Be cautious about where you put your finger at in there to provide direct pressure. Again, metal, wood, glass, plastic, any number of things that could be in there that could again cut your finger, but also push farther into that channel. So. Again, any external bleeding. Let's address this. This is not anything for your test at all. This is just gee whiz stuff for you through my experience. For those of you who are wondering about tampons and putting them in a patient to use them as some type of bleeding control device, I do not advocate that. The Committee on Combat Tactical Casualty Care does not recommend you do that. You still have people out there that are on that kick, that train to do that, but nonetheless, the science is just not there. The common sense is not there. So you really have to, it really, all it does is just plugs the hole. And so the bleeding is still happening inside, but it's just, you just don't get to see it. So essentially you're just psyching yourself out saying, oh, look, there's no more blood coming out. Yeah, we get it. It's not coming out. However, it's still bleeding inside. Okay, so it does nothing for, you're only going to be able to put it in about 2 inches anyway. So unless the bleeding is right there at 2 inches, it's really not going to do much. All right, so just a little myth to dispel if you ever heard about that, or if you have those already in your bag or something, it's pointless. Okay. So same thing, if they've been bleeding for a while, they have a significant amount of bleeding, well, when to treat for shock, try to control that bleeding as fast as we can through, again, the tourniquet, wound packing, direct pressure, things like that. Of course, if need be, if that heart stops, we're going to do CPR, but ultimately we want to try to bandage as best we can, and then transport as soon as we can. Bites, the biggest thing with bites is that they carry a pretty high risk of infection from animals and humans as well. So sometimes humans are even worse, but it depends on who they are. So nonetheless, we want to get them treated and get some antibiotics and things like that on board, and get those wounds cleaned up as best we can. So minor bites, good idea is to go ahead and wash it with soap and water, even if they're going to go ahead and go to the hospital, whether they're going to go POV, privately owned vehicle, or with the ambulance. Good idea, just go ahead and wash it off, try to keep it clean as best you can, wrap it up, and then send them on their way. But major bites, again, wildlife, a coyote maybe, or some type of wild animal that has claws and fangs and all sort of stuff. Sea life, right? So we talked about alligator gall earlier, sharks, any number of things like that. They are definitely going to be, cats, whatever they may be. They can do a pretty good bit of damage. So all the same things apply for our exterior bleeding control. But at the same time, we want to try to keep it clean, and get it bandaged and dressed, and get them to somewhere where they can be explored a little bit more, debride, clean the actual interior part of the wound. So burns, another important. Again, all this stuff is important, but as far as trauma goes, it's one of those that's a pretty sensitive subject. It's a considerable issue to deal with. It's not easy to look at as well. It's not easy to handle. Physically handle them when they're really bad. So very painful. The patient is not going to tolerate it very well. And the risk to the patient for hypothermia, for bleeding, for infection is very high with burns. So it's very important that we, again, keep the burns clean, and try to prevent as much fluid loss and heat loss as we possibly can. So a superficial burn, also referred to as a first-degree burn, is just kind of what you see here. It's a bad sunburn, right? We've probably all had one before. We know it stings and it hurts, and you can't take a shower hardly, you can't lay down. It's man, it sucks, right? So again, red and painful skin. The injury is confined to the outermost layer of the skin, and again, you have that minor, moderate pain level. When we get on up into the second-degree burn, which you can still, obviously you could still get that to be a bad sunburn, but you could still get some of this. But the grease splatter, hot oil, maybe you took the radiator cap off your car too fast before it had a chance to cool down. You get some hot water on you, stuff like that. Maybe kids who, or even adults that get into too hot of water, could potentially have secondary burns. So, doesn't damage the deepest layer of the skin. It's more kind of that mid layer there, and it's usually indicative is the blistering. That's kind of what kind of sets that apart. And again, you may have something where you touch the hot stove with just 2 fingers, and a few minutes later you have a little blister on your fingers. That one little spot is second degree, and the little part around it that's red is the first degree, right? So it could be very, very localized. So as you can see here, like he has the blistering on these certain areas, and then he also has some red marks here. So some red area, this line down here where that EKG lead is or pad is, and that's essentially might be the first degree area right there. But the other parts that are blistered are the second degree. Usually heal within 2 to 3 weeks. Again, fluid loss and moderate to severe pain are the big ones. The bad one, all right, 3rd degree burns, full thickness burns. Again, the full thickness of the skin is involved down to the innermost tissue. Sometimes we will have exposed tendons and ligaments and all sorts of different things. Just depends on what it is. Muscles be showing, that sort of stuff. Again, very gnarly to look at. It's not easy, especially in the face and in the head and all that sort of stuff. But again, a lot of times with this, it's gone down to the nerves, and the pain is maybe absent. It maybe destroyed those nerve endings, and you may not have a whole lot of pain. But the patient lose a large amount of fluid because the body is constantly trying to send fluid to those areas to cool them down and to help fight off infection and that sort of thing. And so it's constantly shunting fluid to those areas, and it's losing that fluid. And also one of the big issues is hypothermia. The body the skin is so damaged now in 2nd and 3rd degree burns that you have the skin is not able to do what it is designed to do, and that's help regulate the body temperature. So hypothermia is a real big issue with this. Again, shock, infection, those are real big issues that we're having to worry about here. So when that fluid loss, again, we have issues with hypovolemia and things of that nature. And then of course, the infection that I mentioned, the skin is not there to protect the body from that infection. Interesting to note, if you look at the patient's right arm right here, you see this red line going down the side of his arm. Okay. That's a cut down more than likely. That is where the swelling has started to increase so much and the body is so charred that it can't flex. It can't it doesn't have any elasticity to it. So the swelling, instead of like when you have normal swelling and your foot gets real big and the skin, gets real big with it. And once it goes away, it contracts and everything's good. The body doesn't have the ability to do that right now. So what happens is they actually have to go in and slice open in a certain manner the skin. So more than likely, he's probably going to have another one of those lines on the other arm if it's affected the same way, down the center of the chest, and so on and so forth, depending on the affected areas, so that he can even breathe. A lot of times it'll get so charred and tight, the skin is so charred and tight that his chest will not be able to expand and breathe. He won't be able to expand his lungs. So they will have to do some specific cut down areas to ensure that he'll probably end up being on a ventilator, but it will allow his lungs to expand. So the rule of nines, this is one rule. There's a couple of other ones out there. This is the one we'll worry about for this class, but it just kind of gives you a little bit of an idea of how to figure the amount of body surface area that has been affected by the burns. So in an adult, the head and arms each equal 9% of the total body surface area. Okay. The front and back of the trunk and each leg equal 18 of the total body surface area. All right. So each one of those is 18. All right. So the front and back. So if the front and back is involved and the legs are involved, then each one of those is 18%. So again, it's slightly modified for children. As you can see here, it kind of breaks it down a little bit more. We're just going over here to the right to the adult. Like I said, the torso, front and back, is 18. The legs, each leg is 18. Genitals is 1. Each arm is 9. Head is 9. Okay. And then as you can see here, as we kind of start going down a little bit for children, but as you can see, the head kind of increases. Okay. So the same in some areas, and some areas are a little bit different. So 9 still for the arms. On the child is 12 for the head and 18 for the infant, because their head is a little bit larger than their, in proportion to their body size, to their torso size. So that means that we give them a little bit greater value. On the legs, as you can see, it kind of goes down 16.5 for the child, 13.5 for the toddler, and then all the genitalia is still 1 all the way across the board. Okay. So again, if you have a little chart like this, you just write it down and keep it somewhere. And you can always, if you have a burn patient, you can always go back and look at it real quick just to kind of refresh your memory. But it's essentially, it's in nines. Okay. It just multiplies by nines. So if you take that and you add those up, you have an idea, you're looking at it and go, okay, this is 9, 18, and we start adding things up. You can tell the next provider, hey, listen, looks to be, this much percentage using the rule of nines. They may reassess it and find you a little bit different number or whatever. Not a big deal. It's just, sometimes open to interpretation, or depending on at what stage you see it at, it may look a little bit different or whatever. So same thing, we want to try to be depending on what it is, especially these full thickness burns, you have to be really careful about it, handling them. The skin could just come right off. Those of you who are firefighters in class, you probably have heard about that before, where they try to drag somebody out of a burning building and their skin just literally came off in their hand. All right. That's definitely a thing. And, so it just, easiest thing to do is put them on a sheet and try to handle them like that. It's, trying to grab up underneath their arms, grab their legs, that sort of stuff is a lot of times just going to make it worse. Okay. So, if they do have blisters, especially on those, second and third degree burns, we're not going to break those blisters. Try to leave them intact as much as you can. Again, dry, sterile dressing, or a burn sheet. There's actually burn blankets that are specifically made for large burn areas. You could try to use those. Excuse me. Patients with large burns must be treated for shock and transported to a burn center. So if you have significant burns, you're probably going to go to a burn center, and there's only a few of them in our area. So it's going to be probably a helicopter ride pretty quickly to an actual burn care center. Types of burns, like I said, we can have internal burns as well as external burns. So respiratory burns are a burn to any part of the airway. We see this a lot, not only, like, say, of course, in fires, in actual fires, where we're just kind of breathing the smoke in general, but in a flash fire where, say, somebody pours gasoline on a fire, or there's a grease fire or something like that, and it flames up. And usually it's the big inspiratory exclamation. Okay. So whenever something all of a sudden happens, you automatically, your body physiologically says, hey, I need some oxygen because I'm about to have to get some yonder. I'm about to have to run. I need to fight. I need to get away. I need to do something physical that's going to require my muscles to have oxygen. Okay? And so the body is automatically going to go and take that big breath in before the feet start moving, or you start, having to throw hands or whatever you got to do. Okay? Especially when you get surprised or something like that. That's the body's way of giving your body a little bit extra oxygen before it has to do whatever it's gonna do. So that inspiratory burn is indicative of that. All right. So whenever you breathe that superheated air in, that's typically how it gets down into the airway during those flash fire type issues. Now, of course, if you're sleeping in your bed, you don't realize it, you're overcome by smoke and heat, superheated gas, that sort of thing, then yes, you're going to just kind of breathe it in, and that's going to do it. And that's some of the signs and symptoms: burns around the face, singed nose hairs, soot in the mouth and nose, difficulty breathing, pain while breathing. You may have some swelling, so you may have some stridor, right? That wheezing type sound because the airway starting to close up. Okay, loss of consciousness as a result of the fire. Again, the stuff that you're breathing in, especially nowadays with the byproducts of combustion, are very, very bad. They are not good at all, and they'll hurt you real bad, and kill you very quickly. Again, we're worried about the airway being compromised. So breathing problems can develop rapidly or slowly, just kind of depends on how bad it is. Again, want to try to administer oxygen. And if we have to, we'll perform CPR. But main thing is monitoring their airway, make sure that's not going to close up. So we're going to try to transport them as soon as possible. You could have chemical burns, and again, if you ingested some type of chemical, potentially, and so again, it could be deteriorated the airway or the esophagus, the area around the nose and mouth, could be burned, and so your lips might swell, your throat swells, any number of things like that. Biggest thing with that, nothing by mouth. Provide O2, transport immediately, and let's monitor the airway. If you have it on the exterior, like we talked about, I think we talked about this before with chemical stuff. It's best if we can get rid of some of that. But again, if it's in the mouth or stuff like that, we're probably not going to be able to do too much for it. Again, on the exterior, we can try to get it off the skin as best we can. And that's kind of what more or less what it's referring to, is just being on the outside of the skin. So if it's doing that, if it's there, we'll try to brush it off. And again, we talked about flushing with water, copious amounts of water, for at least 10 minutes. I mean, really just, holding the hose on it, whatever you got, just trying to get as much of that chemical off as you can. Dry chemical, you can probably try to brush it off, using a hand or, an actual type of brush or something like that. Cover the area with a dry, sterile dressing. And again, we always want to try to go get it looked at and make sure that it can be fully neutralized. It's not going to be, if we put, water on the dry chemical later while we take a shower, is it going to, reactivate or something? We want to really know what that is. So we mentioned that when we talked about hazmat, we want to know what that chemical is, especially it's going to be a very big factor in our patient assessment and our history that we're taking. We want to know what that stuff was. Electrical burns occur when electrical current enters the body at one point, travels through the body tissues and organs, and exits at the point of ground contact. So again, that could be, grabbing an electrical wire. That could be, essentially similar to what we talked about with lightning, right? In environmental factors the other day. So it's pretty similar, right? It's going to enter the body somewhere, say the fingers, the hand, and probably exit somewhere else, right? Whatever's contacting the ground, So that could be the feet or leg, back. It just depends on what your situation is. Big part of that is, of course, you have the the initial entry wound and exit wound. There at those locations, but also the organs and tissues around it and internal portions that we're really concerned about. Cardiac dysrhythmia, where the heart is, stopped, or, it's irregularly beating. Those are some of the issues that we may have. Or, as you see here, it just, you go into full cardiac arrest and it's not beating at all. Again, this is a good opportunity if that happens for the AED. We really want to make sure we put the AED on them and give it the opportunity to see if they are in a rhythm that is shockable, and maybe we can try to restart the heart. Big thing, we want to make sure that the patient is not still in contact with the electrical power source, right? So, vehicle accidents involving power lines, we want to try to stay away from them as much as we possibly can. Any other type of, issue with the patient, around some type of electrical, appliance or something along those lines that caused it, we want to, try to get them off of that and away from it. If you need to, call assistance from the power company before, if you think some of that dispatch information kind of sounds like they may be needed, or an electrician or something like that, go ahead and call them and have them en route. Monitor the ABCs, electrical burn patients, and arrange, the burns themselves, they may be significant, usually localized in one or two areas. Depends on how they grabbed it or touched it or came into contact with it. So, if they stepped on it, it may just be in the foot. It may be the main area. If it's the hands, may just be one or both hands or fingers that are involved. So same thing, we just have to look and see what type of thickness it is of the burn. A lot of times those are going to be, if they held it for a while, you can have some full thickness in a very localized area and then have some second and first degree around that. So again, we're going to treat for those types of burns and transport immediately. Multi-system trauma is just what it kind of implies. There's multiple different parts of the body or multiple body systems that are affected by a traumatic event. So again, we see this with vehicle accidents and any other type of significant incident where explosions and things of that nature, where they may have head injuries, they may have partial amputations, they could have internal abdominal wounds, injuries. So multiple different things that are being taxed in the body. So never easy. It's just one of the things we have to kind of prioritize what's going to kill them first, right? So that's with anything, we want to look and see what's going to be the worst for our patient and treat that first, and go from there. Okay, that's all we really can do. So we do a good trauma assessment, do a good initial assessment, and make sure that we find look at the airway, breathing, circulation, see what's affecting those things, and work those issues out first, and then we can start working our way out systemically and see what else needs to be taken care of. Again, folks, there's a lot in this chapter. It would behoove you to go back and look at that a couple times and read over this chapter in your book. There's probably some more. I know there's some more things in there that we didn't talk about. So make sure you read your chapter well. Go back over this presentation again. Look at those different types of shock. Those are important to know in general, especially for your tests. But make sure that you are understand what shock is, how it affects the body, and the different types of shock that go along with the different types of problems. Bleeding control is one of the big ones, one of the paramount things that we need to be good at. As EMRs, especially, like I said, a lot of this traumatic stuff are thing we can do quite a bit, especially on the external bleeding side and fractures and things like that, and those stabilization type factors, we can do a lot with that. So bandaging and all that, making dressings and all those things are things that you need to be good at. So like I said, this is the essentially the classroom portion of that, and so we'll put that into play when it comes to the boot camp. But the other big thing, going over your patient assessment check sheets, National Registry Patient Assessment Trauma Sheet check sheets. As you can see, they're different, right? So the scene size up and primary survey resuscitation portion is, pretty well the same, right? Airway, breathing, circulation. We're kind of looking for those main things, irregardless whether it's medical or trauma. Once we get past history taken and we get into secondary assessment, however, we're really looking for, really starting to, get our patient, trauma naked if necessary, depending on what's going on with the primary survey. All right, with the rapid trauma assessment, and so we've assessed any life threats up there in our primary survey. Down here in our secondary assessment, we're really looking for, those any other open wounds, bleeding, position of the trachea, jugular vein distension, any issues with the spine, any broken bones in the chest, ribs, anything like that. Abdomen and pelvis, we're looking to make sure it's stable. Upper and lower extremities, right? We're checking for any fractures, all that DCAP BTLS. And essentially with that, if you'll do that, when you start going from head to toe and you go, I'm checking for DCAP BTLS. And if you really, again, like I told you before, you need to write that down. You need to remember that. And as you're going through your assessment, especially your secondary assessment, we're saying that. I'm checking for DCAP BTLS as I go down, as I look for the head. I'm looking at the pupils to make sure they're equal and reactive to light. I'm going through each one of these different process of these body locations, and I'm applying that DCAP BTLS. Okay. So, again, going all the way down, posterior, thorax, lumbar, buttocks. Like I said before, we're, kind of getting into their business a little bit down there, and just a quick check and make sure that everything is how it's supposed to be. All right. I know it's not the glamorous part of the job, but unfortunately it's for thoroughness and good patient care. It's what we have to do. So especially gunshot wounds, like I said, that wound could enter into the upper chest and come out of the right buttock. All right. It just totally depends on the flight of the bullet, the angle, and what it hits along the way. All right. So you never know. Again, look at your critical criteria as you go in there, as you go down, and make sure that you are adhering to those and not skipping those. And that's going to be the big fail points for that. But again, DCAP BTLS and making sure that we are being thorough with our assessment, our secondary assessment especially, is key, and making sure that we address all those life threats in the primary. Does anybody have any questions for me from tonight? Nobody? There's only 3 of you, but nonetheless, guys, listen, like I said, this is the stuff to be good at. All right. This is the stuff that we deal with quite a bit. And I know almost all of you have probably already dealt with it before. You've probably seen it before. So, it's one of those things that's very important for you guys to be good at. So, without any other questions, tonight's class code is going to be R0010, R0010. Again, making sure everybody, for those of you who are not here, make sure you're going in there and take your quizzes. All right, I say it every class. There's several of you that are considerably behind. Okay, you need to get in there and do that. If not, we're going to have a conversation pretty soon about going forward in class. Okay, you can't get too far back, or you're just not going to be able to finish it out. Okay, so make sure you get in there and you're reading over your material and taking your quizzes. All right, again, as I said before, if you have any issues, concerns, questions, please reach out. You want to know a little bit more about something that we covered or whatever, reach out to me and I'll be happy to provide you with some resources and we'll talk about it. All right. If nobody has any other questions, that's it for tonight. You guys have a good one, and we'll see you on Thursday.